So next objective is the clinical features that suggest a malignant cause of back pain include occurrence at night. So when there is a back pain, the malignancy causing back pain usually occur at night. They are not related with the rest because the malignant cells release prostaglandins all the time or analgesics. Advanced age and systemic symptoms all give clue towards malignancy, and common malignancy with a propensity for bony mets. So bony metastasis can occur in prostate, breast. So prostate goes directly into the lumbar vertebra, breast goes into the lumbar vertebra, kidney, thyroid, and lungs. So kidney, thyroid, lungs. So kidney and thyroid. So thyroid and lungs are close. Kidneys and kidneys are close towards the bones, so bony vertebrae. So kidney, thyroid, and breast. So breast and prostate. So these are common malignancies that can cause bony pain, so back pain. Usually they occur at night. So next, so LFS is Lee-Fraumeni syndrome. So Lee-Fraumeni syndrome is caused by an autosomal dominant. So Lee-Fraumeni, so the name itself looks very dominant. So it is an autosomal dominant mutation in the tumor suppressions in P53. So P53 is one of the most commonly implicated genes among all the others. That is one of the most important causes for onco cancers. Leukemia, sarcomas, and tumors of the breast, brain, adrenal cortex are most common. So Lee-Fraumeni syndrome is caused by an autosomal dominant mutation. So Lee-Fraumeni syndrome occurs because of the autosomal mutation in the P53 gene. Leukemia. So leukemia, sarcoma. Leukemia means the cancer of the blood, muscles, and the breast. So blood, muscles, breast, BMB, brain. So all these start with B. So leukemia is blood, sarcomas, muscles, and tumors of the breast, brain, adrenal cortex are the most common. So leukemia, sarcoma, BMB. So B for blood vessels, M for muscles, sarcomas, B for breast and brain, and adrenal cortex. So B after C. Adrenal cortex are most common cancers that are associated with Lee-Fraumeni syndrome. Now let's go to the next point. Following the endothelial damage, von Willebrand factor. So when there is damage in the endothelium, von Willebrand factors bind to the GP1B receptor in the platelets to mediate the platelet adherence, and the RCOA measures platelet agglutination. So that is a ristocetin test. So ristocetin test measures platelet agglutination via binding of GP1B receptors to BWF. So it will be abnormal in von Willebrand deficiency, but will correct with the addition of normal BWF containing plasma. So RCOA, ristocetin coenzyme assay, I think so. The RCOA measures platelet agglutination via binding of GP1B receptors to von Willebrand factor. So it will be abnormal in von Willebrand factor deficiency. So when there is deficiency in von Willebrand factor, the underlying collagens are not functional. So when ristocetin is given, so it cannot measure the platelet agglutination, but it will correct the addition of normal plasma. So normal plasma can be corrected with the addition of ristocetin. So I didn't actually totally understood the concept, but I think I'll look into it. So you can I'll update you later. So this let me just highlight it. The highlighting feature is available here. So yeah, I'm just like you guys, and yeah, let's just see what happens now. Next, so HFE protein. So it is one of the hemochromatosis protein. HFE protein mutations are most common cause of primary hemochromatosis. Inactivation of the HFE protein resulting in decreased hepcidin. So hepcidin is present in the basolateral side of the intestinal epithelium. So in the basolateral side there is hepcidin, and HFE protein causes the mutation of hepcidin. So normally hepcidin prevents the intake or entry of iron into the blood, but because of mutation, hepcidin cannot prevent or block the entry of iron into the blood. Therefore there is excess iron accumulation in the blood, causing hemochromatosis, which again leads to iron overload and hence cirrhosis and hepatocellular carcinoma. So this is the point that is been discussed. So the prognosis of CRAC. So CRAC, the prognosis of CRAC. CRAC. So what might be the main meaning of CRAC? So is it colorectal carcinoma? No, so it is cervical cancer patients. So cervical CRC channel in cancers. Yeah, the 5-year survival rate is considerably lower in cervical cancer patients with high expression of STIM1. So, prognosis of cervical cancer. Cervical cancer is directly linked to the stage of the tumor, not to the grade. So, it depends more on the TNM staging T. So, the T in the TNM staging of cervical cancer is primarily responsible for the prognosis of cervical. So prognosis of cervical cancer depends on T. Similarly, the urethral cancer was also dependent on T, not the grade. So grade 1, 2, 3, and 4 does not carry much value in case of the prognosis of CRAC, that is cervical cancer. So now carcinoma tumor, these are some of the neuroendocrine tumors are confined. The carcinoma tumors confined to the intestine does not cause carcinoid syndrome, as their secretory products are metabolized by the liver. So in the intestine, if there is carcinoid tumor in the intestine, it does not cause carcinoid syndrome. Carcinoid syndrome because their secretory products, like all the neuroendocrine hormonal things that they produce, are metabolized by the liver before entering the system circulation. Hence, the metabolized byproducts does not carry any cause any symptoms. In contrast, intestinal carcinoids that metabolize to the liver, and extraintestinal carcinoid release vasoactive substances that avoid fast pass metabolism, resulting in carcinoid syndrome. So, other in contrast, intestinal carcinoids. So, which are in the intestine, they does not cause carcinoid syndrome, but those which bypass, which are not present in the liver, for example, bronchial carcinoids, or those which bypass the liver, or which bypass any first pass metabolism, that is the metabolism biometabolism that occurs in the liver. It can cause carcinoid syndrome because it releases vasoactive mediators or substances like nitric oxide, like vasodilator substances in the blood, hence causing flushing, diarrhea, bronchospasm, and thus causing carcinoid syndrome. So now let's talk about the inherited causes of hypercoagulability. So inherited cause of hypercoagulability. So hypercoagulability, which falls under the Burkle's triad. So Burkle's triad contains three primary things, which are endothelial injury, vascular stasis, and hypercoagulability. So the inherited cause of hypercoagulability should be considered in patients younger than age 50. So usually hypercoagulation occurs after the age of 50, but inherited means genetic. Any cause of hypercoagulability should be considered in younger patients who is present with thrombosis and no obvious explanation for an acquired prothrombic disease. So if there is no any explanation for any prothrombic disease, for example, in young stroke, you need to consider some other factors like the inherited cause of hypercoagulability, like factor 5 lead mutation, which causes factor 5A resistance to inactivation by activated protein C. So yeah, factor 5A resistance to inactivation by activated. So protein C generally causes the factor 5, factor 5, which is involved in the coagulation cycle, is actually inhibited by protein C. But factor 5 lead-in mutation is a mutation in the factor 5 coagulation protein, where protein C, activated protein C, cannot break or inactivate factor 5. Hence there is continuous activation of factor 5A, thus causing more coagulation, and it may account for approximately 20% cases of atypical venous thrombosis. So now let's talk about the VAS. So VAS, I think VAS. What is VAS? It's not. Was means Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome. It is actually a X-linked. It is an X-linked recessive disorder. So it is an X-linked recessive disorder, originally described as the clinical triad of thrombocytopenia. So platelet count decrease. There is eczema. So let's suppose a person who has eczema. So when he scratches that eczema, which is allergy, irritating, with a scratch of the eczema, there occurs some bleeding-like spots, which is due to thrombocytopenia, and there is a recurrent pyogenic infection. So bacterial infection occurs in the same site. So Wiskott-Aldrich syndrome is a triad of eczema. Number one, eczema. Number two is thrombocytopenia. So irritation causes irritation when there is itching by eczema, then there is bleeding spots by thrombocytopenia, and there is pyogenic infection due to bacterial infection due to lymphocyte and T lymphocyte deficiency. So there is deficiency of lymphocyte, B lymphocyte and T lymphocytes. Onset of disease is early in life with thrombocytopenia present at birth and eczema and repeated infections, particularly by encapsulated organism following at 6 to 12 months of age. So because of it, there is early manifestations of the disease because of thrombocytopenia, which is present at birth. So when the baby is born, it is bluish in color. Sorry, let's say there are multiple bleeding spots throughout the body, and eczema as well as repeated infection because of repeated infection occur because of encapsulated organisms. Mostly at 6 to 12 months of age, because until 6 months of age, maternal antibodies are usually sufficient for to combat any bacterial or viral infections. So okay, so SDN means hemolytic disease of the newborn. So hemolytic disease of the newborn most commonly occurs from maternal sensitization to RS antigens during a prior pregnancy or with an RS positive fetus. So when the fetus is positive, that positive part goes to a negative mother. So there's positive part in the negative mother. So that positive part in the negative RS negative mother induces the production of antibody in the mother. So thus antibodies attack the fetal RBCs. Usually the contact of blood from the fetus to the mother occurs during delivery in the first pregnancy, but in the second pregnancy, the maternal antibodies are already sensitized enough to combat any RS positive fetus in the next pregnancy. Thus, the antibody in the mother side attacks the second fetus and thus can cause hemolytic disease in the newborn. In subsequent pregnancy, maternal anti-IgG. So these are IgG antibodies, not IgM. So they cross the placenta and causes of severe AIHA, means autoimmune hemolytic anemia in the fetus, and life-threatening hydrops fetalis. So it is a very known concept. I hope you know that. Okay, all right. Now let's talk about immature. So immature T lymphocytes. So immature T lymphocytes. So a T lymphocyte which are immature express both the CD4 and CD8 cell surface antigens. So when there is a T lymphocyte, so T lymphocyte has CD4 antigen and CD8 surface antigen in addition to a complete T cell receptor or a pro T cell receptor. So there is T cell receptor, pro T cell receptor, as well as CD4 and CD8 cell surface antigens. This lymphocyte exists in the T cells, okay, where they undergo positive selection, and in the TM, so the thymic cortex where they undergo positive selection, and in the thymic medulla when they undergo negative selection. M is close to N, so medulla. In the medulla there occurs negative selection, whereas in the cortex there occurs positive selection. So immunity cell T lymphocytes express both CD4 and 8 surface antigen in relation to complete TCR and pro-TCR. These lymphocytes exist in the T cells with undergo positive selection, and in the thymic cortex in positive selection, thymic medulla onto undergo negative selection. So next question is about pilocytic astrocytoma. So pilocytic astrocytoma are most common brain tumors in children. So pilocytic astrocytoma are the most common. So grade 1 astrocytoma are most common brain tumors in children. They frequently arise in the cerebellum. They occur in the cerebellum and can be differentiated from medulloblastoma by the presence of both cystic and solid components on imaging. So cystic as well as solid components. So they are benign brain tumors. There are both, since it is benign, there are some cystic component as well as solid component. Solid component is more associated with some malignant brain tumors, whereas cystic as well as solid components is more associated with pilocytic astrocytoma. Both vitamin K and fresh frozen plasma are used for reversing warfarin-induced anticoagulation. So warfarin, when warfarin is taken, then it does not does not cause it decreases the reduced amount of vitamin K, and thus can cause bleeding. Therefore, vitamin K, when given, reverses the side effects of warfarin, as well as fresh frozen plasma also contains vitamin K. Fresh frozen plasma reverses warfarin side effects, whereas vitamin K requires time for clotting. Factor resynthesis. So vitamin K reduces the time for clotting factor resynthesis. So clotting factors are resynthesized fast. So yeah. Okay, vitamin K is necessary for the carboxylation and functionality of coagulation 2719. So 2719, 1927. So 2719. So 2719, carboxylation and functionality is assisted by vitamin K. Newborns which does not receive the prophylactic supplementation are the risk of bleeding complications. So there's increased bleeding tendency in newborns who does not receive vitamin K. So patient with cystic fibrosis, where there is pancreatic insufficiency causing loss of fat soluble vitamins, including vitamin K, which is a fat soluble vitamin, and therefore there are bleeding. And also due to poor absorption of fat soluble vitamins. So cystic fibrosis also has, because of pancreatic insufficiency, the digestive enzymes such as lipase cannot is not properly formed, properly secreted, and thus fat soluble vitamins are excreted in the excreta. So aspirin aspirin is an NSAID that irreversibly inhibits COX-1 and COX-2 enzymes via acetylation. So ASA means aspirin inhibits both COX-1 as well as COX-2 enzymes via acetylation. So DNA acetylation and DNA methylation are two very important steps that increases or decreases the genetic transcriptional activities. Therefore, DNA is activated by methylation and inhibited by acetylation. So NSAID aspirin when taken uh, irreversibly inhibits COX-1 and COX-2 enzymes, cyclooxygenase 1 and 2 enzymes via acetylation. So acetylation causes inhibition of COX-1 and COX-2 enzymes. In contrast, other NSAIDs, diclofenac, ibuprofen, indomethacin, reversibly inhibit COX-1 and COX-2. So aspirin is irreversible, whereas other NSAIDs like diclofenac, diclo, ibuprofen, brufen, and indomethacin reversibly inhibit COX-1 and COX-2. So okay. So glomerulonephritis, including photosensitive skin rash, malar rash, as well as arthralgia in a young woman. So if there is a young woman with glomerulonephritis, photosensitive skin rash, and arthralgia, it is a risk of SLE. Up to 30% of patients with SLE have antiphospholipids antibodies. So antiphospholipid antibodies also associated with early pregnancy loss, and 30% of patients with SLE also have antiphospholipid antibodies, which can cause paradoxical apidity prolongation and a false positive RPR or VDRL. So, so it causes apidity prolongation. So apidity prolongation occurs, and first false positive RPR. So it looks like the SLE patients with APLA also have syphilis. So there is false positive RPR or VDRL, and there is a paradoxical apidity prolongation. Patients with antiphospholipid antibodies are at risk for venous and arterial thromboembolism and unexplained recurrent pregnancy loss. As I said, there is a recurrent pregnancy loss in APLA. So APLA have also including recurrent pregnancy loss. So why does recurrent pregnancy loss occur in APLA positive individuals? So in APLA positive individuals, there is more chances of thrombosis. Placental thrombosis results in decreased blood supply to the fetus, and the connection between the mother and the baby is not proper, hence there is a recurrent pregnancy loss. Hepcidin. So now let's talk about hepcidin. Is a polypeptide synthesis by the liver. So liver synthesizes hepcidin that acts as a central regulator of iron homeostasis. So it decreases the amount of iron absorbed from the intestine. So high iron levels and inflammatory condition increases in the same hepcidin. So when there is a high amount of iron or high amount of when there is more inflammatory condition in the body, then hepcidin levels are decreased. So hepcidin level increases because iron needs to be reabsorbed less. Therefore, there is more synthesis of hepcidin, hypoxia, and increase erythropoiesis. So hypoxia and increased erythropoiesis act to lower hepcidin levels. So to increase erythropoiesis, to increase the RBC production, more iron needs to be absorbed. So to absorb more iron, there should be less hepcidin. So hepcidin blocks iron absorption. When hepcidin is less, more iron is absorbed, hence more erythropoiesis occur. Low hepcidin levels means high iron increases the intestinal iron absorption and stimulate iron release by the macrophage. So okay, all right. Vitamin B12 and B9 means folic acid deficiency causes similar heme pictures. However, neurological dysfunction is in patients with vitamin B12 deficiency. So, folic acid deficiency and vitamin B12 deficiency both cause macrocytosis, megaloblastic anemia, but neurological dysfunction because of methylmalonic acid deposition in the neurons, or maybe due to homocysteine deposition in the neuron, it's more a more neurotoxic effect is seen in vitamin B12 patients. If megaloblastic anemia due to vitamin B12 deficiency is mistakenly treated with vitamin B9 alone. So if there is a vitamin B2 deficiency, but if we only give vitamin B9, neurological dysfunction can worsen because there is some you know there is because one pathway runs smoothly while the other pathway is inhibited much, thus more deposition of neurological toxin, for example homocysteine, is present, thus resulting in neurological manifestations. Okay, we are completed up to page 2. We'll be completing more pages in subsequent videos. Thank you.